I would like to thank iCare to organize this lunch symposium and put together these wonderful talks. In this presentation, I will talk about how microperimetry or macular perimetry or fundus-driven perimetry bridges the retinal structure and function, and recent advances that allow more improved functional evaluation, and why it has become increasingly important in macular disease management, and not only in daily clinical practice but also in recent clinical trials. What is microperimetry? Microperimetry is a psychophysical method that enables the assessment of retinal function, specifically across the macula. And it combines the retinal imaging with the sensitivity and the fixation analysis, and allowing the real-time fundus visualization and fundus correlated functional testing at the retinal locations. And real-time retinal tracking compensate for the eye movement and fixation instability, and allowing the retinal sensitivity to be measured and registered at the precise retinal locations. And this makes microperimetry particularly useful for evaluating the structure-function relations in macular diseases. So over the last 2 decades, the microperimetry has been widely used to detect and characterize and monitor macular diseases, and it's useful for detecting early functional changes and tracking the disease progression over time and assessing the treatment outcomes. And in addition, the fixation analysis that provides the clinically meaningful information, especially in patients with central vision loss. So among the available devices, the MAIA second generation model has been considered the gold standard in microperimetry and cited in over 1,000 scientific publications. So today, microperimetry is gaining increasing interest, as it is among the key functional endpoints in the gene therapy and new drug validation trials. And as mentioned by Professor Chang, it can be used in the surgical field before and after. So macular function is not fully reflected by the central visual acuity, especially in treatment targeting early disease stage or before the foveal involvement. And based on the emerging clinical trial data, so microperimetry is increasingly being adopted to monitor disease progression and functional changes in real-world clinical practice as well. The OAK trial, one of the Geographic atrophy treatment validation, and evaluated the functional benefit using the microperimetry MAIA and as an independent outcome measure. So retinal sensitivity changes were analyzed longitudinally to assess the treatment-related functional improvement, highlighting the value of microperimetry as a clinically meaningful endpoint. So iCare MAIA is TrueColor Confocal Microperimeter that evaluated macular structure and function by combining imaging sensitivity and fixation analysis. And this allows clinicians to assess the functional changes directly related to retinal morphology. The third generation MAIA, the new one, came out and features a 60-degree field of view and TrueColor Confocal imaging capability with the sharp image details. And the confocal technology improves the quality of the retinal tracking system also, and the overall image quality provides the better structure and function correlation. So in this old Arguello case, and MAIA 3 provides a very high quality fundus images. Area of non-perfusion can be suspected on the fundus examination, and microperimetry allows the precise identification and delineation of the functional impairments in these regions. And this enables the accurate and reliable structure-related function assessment with a level of the detailed comparable to the OCT thickness map. And the third generation MAIA also provides the improved ease of use, so automation, including the auto alignment and autofocus, and reduce the operator dependency and shorten the examination time, which is important for routine clinical practice. And this video was recorded on the mobile phone during the actual microperimetry examination, and on the large screen that we can continuously visualize the retina and confirm that the examination is proceeding properly in the real time. So thanks to the eye tracking system, you can see that the test grid remains stable at the intended retinal location and despite the patient blinking. And this demonstrates how MAIA ensured repeatable and reliable functional testing under the real clinical condition. Now I'd like to share my clinical experience on MAIA 3 over the past 8 months. So this is an neovascular AMD patient, so reported the improved vision, but darker visual sensation after 2 initial anti-VEGF injections. So although the visual acuity remained stable and the exudation resolved after treatment, the retinal cavity at the fovea side enlarged. And the microperimetry showed the decreased sensitivity of all area on your right, and increased the number of scotoma spots and a broader fixation area, and highlighting the functional changes not reflected by a visual acuity. And this case showed the old red lesion with a large geographic atrophy, and especially in the left eye. So microperimetry demonstrates a leftward preferential retinal locus shift in both eyes, and the fixation located within the atrophic area, as you see on the fundus fluorescence. So this highlights the value of the microperimetry in identifying the fixation behavior and quantifying the remained retinal function and the functional adaptation in advanced macular disease. And in pachychoroid atrophy, the preferential retinal locus is located just at the margin of the atrophic lesion, so highlighting the fixation adaptation at the border of the preserved retina, and the margin is not that damaged in the pachyatrophic case. And in the retinitis pigmentosa, microperimetry identified residual macular function despite the advanced structural degeneration. In the diabetic retinopathy, the microperimetry enables the detection of reduced retinal sensitivity even when the visual acuity remained relatively preserved, and this allows the functional assessment beyond the conventional visual acuity test across the macula. And I look forward to the use of microperimetry in early diabetic retinopathy treatment trials. And another advantage of MAIA 3rd generation is that the test grid can be customized according to the disease. So in our clinic, the grid focus on the central 3mm area is used for the geographic atrophy, and the grid is optimized for the intermediate AMD using a wide grid covering the central 6mm area, and this 6mm area allows the more detailed functional evaluation across the all intermediate sectors. So we were also able to superimpose the microperimetry results on the multimodal imaging, such as an EMPHAS sub-RPE SLAT or the fundus autofluorescence in patients with geographic atrophy, enabling the rapid and intuitive structure function correlation. So we then compared the retinal sensitivity across the different lesion type using the registered microperimetry points, and as shown in the table, so retinal sensitivity was slightly reduced, but significantly, it was significant over the reticular pseudodrusen and drusen by a mean of 1.4 decibel. More substantially reduced over the hypertransmission defect without geographic atrophy, the iRORA area by approximately 6 decibel with a mean retinal sensitivity of 10 decibel. So within the established atrophy lesions, the retinal sensitivity showed a near complete loss. So here, this table shows the 3 months changes in function, the best corrected visual acuity, and overall retinal sensitivity remains stable, whereas the retinal sensitivity of a hypertransmission defect without geographic atrophy, iRORA area showed a significant decline even within the 3 months. So among 128 points over the hypertransmission defect without geographic atrophy area, the 8.5% SPUS progressed to the scotoma within the 4 months, highlighting the value of lesion-specific retinal sensitivity in geographic atrophy follow-up. In my experience, a take-home message is microperimetry, the macular perimetry, provides the functional information that goes beyond visual acuity and allowing direct and meaningful structure-function correlation. And with the MAIA third-generation system, this assessment has become more accurate and practical in daily clinical use. In conditions such as geographic atrophy, the microperimetry supports earlier detection and monitoring of functional changes in both clinical practice and research. Thank you so much for your kind attention.
Actually, in geographic atrophy, early AMD, the patient visual acuity is pretty good. So in that case, visual acuity cannot show us the patient's real retina function change. The MAIA provides the imaging and the retina sensitivity analysis and fixation analysis. So combined 3 of those, the MAIA allows us to see the retina and do a real-time retina sensitivity test while we are looking at the fundus. So MAIA can show the retinal sensitivity all across the macular area. So we can detect very little small change in the retinal function, the quality change and function change, and where the retinal pathology is. We just focus on the best corrected visual acuity when we manage our patient, but we have right now more earlier stage treatment and some treatment that not include the foveal center. So we need to change our mind to look at the area outside the fovea, and then we can check the retinal function with the MAIA perimetry with a short time and a very automatic way.